Hi everybody, this is Dr.T.SelvaKumar, reader from SRM Dental College, Department of Oral Maxillofacial Surgery. Today we'll discuss about the nasolabial flap for intraoral reconstruction. Coming to the anatomy, the nasolabial flap, uh, is it's a flap, the tissue which is taken from the nasolabial crease. So which is 1 or 2 centimeter lateral to the alar rim and extending inferiorly up to the commissure of the oral cavity. So the main blood supply of this flap is the facial artery, and the branches of the facial artery, the superior labial artery, is the main branch which supplies the skin panel here. It extends upwards superiorly and forms an angular artery and extends up to the medial canthus of the eye. So the superior part of the flap is a axial pattern, whereas the inferior part of the nasolabial skin is considered as a random pattern. You have transverse facial artery also supplying the inferior part of the flap. So there are other branches of the facial nerve which innervates the muscles of the facial expression. We have zygomaticus major. The superficial fibers of the zygomatic major gets inserted into the nasolabial crease, and it can also be harvested as a random pattern flap also. So today we'll discuss a case of submucous fibrosis where the patient came with the complaints of difficulty in opening the mouth. The patient complaint was burning sensation for past 2 months and mouth opening was restricted. There was no other relevant medical history. So he was a chronic cigarette smoker, and along with the betel nut chewing habit was there for 20 years. So general examination, he was apparently normal. Mouth opening was restricted, only 29 millimeters. Intraoral examination shows there is a blanching of the mucosa and there's some presence of white patch in the right buccal mucosa, and you can see the deviated uvula, which is deviated on the right side. So on palpation, there was a fibrous band felt in the left and right buccal mucosa, and there was some white patch on the right buccal mucosa. So we have taken a biopsy of the patch, came as a severe dysplastic lesion, and overall the diagnosis was a oral submucous fibrosis was made. So our plan of surgery is to do a fibrotomy and do a bilateral coronoidectomy along with reconstruction with nasolabial flap. So this is on the left side is the picture where the fibrotomy was done, and this is the defect. And the center picture is the coronoidectomy. The coronoid was removed, and intraoperatively, we were able to achieve more than 35 millimeters. The bilateral, the contralateral coronoid was also removed. Right. So coming to the our flap, this is the nasolabial flap markings. So the nasolabial flap is a versatile flap which is used for reconstruction of intraoral defects. Can use for reconstruction of the upper lip, the floor of the mouth, the cheek, the chin, etc. So before harvesting, you should mark the flap, the extension. So nasolabial flap, you can get a width of about 2 centimeter and you can get a length of about 6 centimeter. So the best idea is to take a gauze and then you can keep a pivot point at the inferiorly base where it's going to be rotated, and then you can measure intraorally. So this flap, either you can take it for intraoral reconstruction, mainly inferiorly based is used. Okay. So the second picture is the flap is raised above the muscles of facial expression, taking care not to damage the facial artery and facial nerve, and the inferior portion is just the skin and subcutaneous tissue is incised and it is tunneled into the defect and then sutured. See that there's no damaging or the flap is not kinking or it is not crushed during the insert. This is on the right side and this is the harvest on the left side. This is the flap inserting. The flap is tunneled and inserted into the defect which is created during the fibrotomy procedure. This is a closure of the nasolabial flap. We get good aesthetic outcome, and the closure is we have to undermine the skin edges and subcutaneous tissue and get a good tight closure so that there is no communication from the oral cavity. There is no salivary communication from the oral cavity. So this is a post-op patient able to open the mouth more than 35 millimeter. So the only one problem with this flap in males is this growth of hair in the region. So after some time, after 6 to 8 months, tends to mucosalize, and the hair pattern, the hair growth tends to become less, and finally gets mucosalized fully. So coming to the complication of this flap, there can be an edematous bulky flap. You might need to do a flap revision after 3-4 months, after maybe a month or so. Sometimes you can get a flat cheek if the thickness of the flap is more. When you try to advance, when you try to undermine and advance, you can have a flat cheek. Okay. So again, wound resistance is common for all flaps. If the flap is crushed or there's a torsion in the flap, then if there's any compromise in the blood supply, then it's going to go for wound resistance. And flap necrosis, again, patient medical consideration medical condition has to be taken in consideration. We have flap necrosis, diabetic patient, in irritated patient. We have to be more careful for look for flap necrosis. Okay, and hair growth is a minor complication. After sometimes tends to become mucosalized. Very rare complication is the extropion of the lower eyelid. So the superior extension of the flap, if it is extended up to the middle canthus, when you try to do undermining and closure, you can have a possibility of ectropion. That is also possible, so but very rare. Okay, so that's about the nasolabial flap. Thank you. If there's any suggestions or questions, you can mail them. Thank you.